Neurology Quiz number 96. Describe pathogenesis, clinical features, investigation and treatment of Moyamoya disease. MMD is a chronic and usually bilateral cerebral vasculopathy of unknown etiology. There is progressive narrowing of the terminal intracranial portion of the internal carotid artery and its proximal branches. The vasculopathy is non-inflammatory and non-atherosclerotic and characterized by endothelial hyperplasia and fibrosis. A network of abundant and fragile collateral blood vessels develops at the base of the brain, and these are known as Moyamoya vessels. The term Moyamoya syndrome is used when the vascular changes are associated with underlying diseases. Such diseases may be inherited or acquired. Some of these inherited and acquired conditions are mentioned below. Epidemiology and genetics. MMD is most common in East Asian countries, mainly Japan, Korea, and China, but Western countries have noted increasing incidence of MMD. Family history of the condition has been reported in 10 to 15% of patients. The ring finger protein 213 gene is a susceptibility gene for MMD, and different variants are found in different populations. The mode of inheritance is unknown, but data suggests that it is most likely autosomal dominant with incomplete penetrance. This figure shows the pathology. In A and B, the lumen is narrowed, there is intimal thickening, hyperplasia of the tunica media, and an irregular internal elastic lamina indicated by the black arrows. In C and D, there is vacuolar degeneration in the smooth muscles in the tunica media. Clinical features. There is a bimodal age distribution with peaks around age 10 and 40 years. Previously, it was reported to be more common in women, but recent series showed that the incidence is not different in the two sexes. Cerebral ischemic events in the form of TIA and stroke are the most common presentation in all Moyamoya patients. Intracranial hemorrhage occurs mainly among adults. In children, the disease typically manifests as TIA or ischemic stroke. Attacks can be precipitated by hyperventilation, such as during crying, as the hyperventilation induces cerebral vasoconstriction and aggravates cerebral hypoperfusion. Chorea can occur in children due to the Moyamoya dilated collateral vessels in the basal ganglia. Children can also suffer from intellectual disability. Adults frequently present with hemorrhagic stroke in addition to ischemic strokes. This results from rupture of the Moyamoya collaterals in the deep areas of the brain, such as the basal ganglia. Intraventricular hemorrhage is common due to the proximity of the hematoma to the ventricles. Cerebral aneurysms can develop, causing subarachnoid hemorrhage. Seizures can complicate both ischemic or hemorrhagic strokes. Headaches can occur in children and adults and are most likely due to dilated transdural collaterals, stimulating the dural nociceptors. Investigation. DSA is considered the gold standard for diagnosis. The angiographic diagnostic criteria for DSA as well as MRA are listed below. The Suzuki classification of the angiogram requires serial studies and classifies development of MMD into 6 stages. In stage 1, it begins with the narrowing of the terminal ICA. In stage 3, there are prominent collateral Moyamoya vessels, and in stage 6, there is disappearance of the collateral vessels, and the major cerebral arteries, and the brain gets its blood supply almost predominantly from external carotid artery anastomoses. This figure shows a conventional angiogram with typical appearance of MMD. There is narrowing of the terminal internal carotid artery and disappearance of the anterior and middle cerebral vessels. Thick and distinct Moyamoya vessels are seen. MRI and MRA are non-invasive methods for diagnosis. Three-dimensional time-of-flight MRA can identify findings of MMD non-invasively without the need for IV contrast. FLAIR images and T1 enhanced MRI can show leptomeningeal collaterals, known as the IV sign. High-resolution vessel wall imaging shows concentric enhancement of bilateral distal ICAs. EEG is performed in patients with seizures. A distinctive finding has been described called the rebuild-up phenomenon. This consists of reappearance of high-amplitude slow waves 30 to 60 seconds after termination of hyperventilation and usually resolves within 10 minutes. Here the figure on the left shows an MRA with narrowed distal internal carotid artery and proximal circle of Willis vessels, while the figure on the right shows an MRA with narrowed proximal vessels and prominent Moyamoya collaterals. Here the figure on the left and in the middle is a FLAIR MRI which shows bright sulci or leptomeningeal IV sign which may be caused by slow flowing engorged pile collateral vessels and thickened arachnoid membranes. On the extreme right is a T1 weighted MRI with contrast which shows leptomeningeal enhancement or the contrast enhanced IV sign. Treatment. There is no curative treatment. Early diagnosis with timely surgical intervention is important. Medical treatment. Acute treatment of ischemic and hemorrhagic stroke is performed as per standard protocol. Utility of thrombolysis has not been studied and may be risky due to possibility of hemorrhage from the fragile collateral vessels. Antiplatelet agents. Aspirin has been conventionally used for stroke prevention, although there is no convincing evidence of its benefit. However, use of antiplatelet agents for prevention of ischemic events in surgical and non-surgical patients may be reasonable according to the AHA and American Stroke Association 2021 guidelines. The antiplatelet agent celiostazole, which also has a vasodilating effect, may improve cerebral blood flow, cognition, and survival, but this needs further validation. Headaches in MMD may be migraine-like. Anti-migraine agents that cause vasoconstriction or lower the blood pressure should be avoided. Surgical treatment. Studies support the benefit of revascularization procedures in symptomatic MMD. Surgical treatment consists of revascularization procedures that can be classified as direct, indirect, or combined. Direct is creation of a direct extracranial intracranial anastomosis, usually between the superficial temporal and the middle cerebral artery. Direct bypass has the advantage of immediate revascularization, but it is technically more demanding with higher potential for peri-procedural complications. Indirect, vascularized tissue supplied by the external carotid artery is placed in direct contact with the brain surface, resulting in ingrowth of new blood vessels to the underlying brain or synangiosis. Indirect bypass relies on angiogenic proliferation over days or weeks so that there is a delay in revascularization. However, the procedure is easier to perform. Endovascular treatment for ischemic MMD with angioplasty or stent placement is not recommended because of low rate of success and high rate of complication. Hemorrhagic aneurysms associated with the condition can be treated either endovascularly or with revascularization surgery. Here the figure on the left shows the direct surgical procedure with creation of an anastomosis between the superficial temporal artery and the middle cerebral artery, while the figure on the left shows the indirect method with placement of vascularized tissue on the surface of the brain.